Good evening and a very warm welcome to all of you. This is a biannual, twice-a-year event, our Stories of Illness and Health evenings. I'm Sandra Fissman, just by way of introduction, and I'm a child and youth psychiatrist, and I really feel very privileged to be your facilitator for another one of these patient story series. I want to thank, on behalf of the planning team, each of you for being here this evening. So very briefly, just a little bit about the purpose of hearing patient stories. Why do we do this? So there are a few reasons. First of all, it's important to listen, to honor, and to learn from those of us who've experienced illness, and for all of us to bear witness to suffering. Secondly, we want our stories and the discussions that they evoke, and you'll find the discussion becomes very meaningful to inspire change in our healthcare system, because we need that change. The third reason is that sharing our stories helps us to heal, and it enhances that very essential therapeutic relationship that really, when it's at its best, is a partnership. It's a patient-provider partnership. And finally, and so importantly, sharing our illness stories helps us as healthcare providers to promote authentic, humanistic, real person-centered care, not just in words, but in actions. So at tonight's Stories of Illness and Health, we're so honored to hear from three people, all of whom have been or are in the healthcare system. So we have Ellen Rosen, who is a retired nursing executive and was my partner in crime for a lot of years, in goodness too. And then we have George Kim, who is a family physician, and Shannon Ontfield, an obstetrician and gynecologist. I think it's important to acknowledge that sharing this very personal experience takes tremendous courage. It's not easy to stand up here and do this, and it can be challenging, perhaps even uncomfortable, and certainly emotional for some of us. We all have our own personal stories that shape our lives and shape our illness journeys. Our personal experiences may also affect how we report the stories of others. These experiences could be our own illness or illness in those that we've observed, in those who are close to others. So as your moderator for tonight, I come to you with a great deal of humility. Our speakers come to you with tremendous courage, and we trust that you as participants come with openness and respect for what's being offered. So without any more delay, I'm going to ask Dr. George Kim to come to the podium.
Thank you, Sandra, for opening the evening for us tonight. Good evening to friends, colleagues, strangers who will become friends by the end of tonight's event. So as introduced, my name is George Kim. I'm a family physician in town and also have the privilege of being a faculty member in the Department of Family Medicine at the Schubert School of Medicine and Dentistry, and pride myself on being a teacher as well as a healer. I have the honor of being married and having two beautiful children who are at events tonight, so they're not with us tonight. But as I share my story, my family becomes very apparent, their importance in who I am today, where I've been, and the journey that connects the two. I've actually had the opportunity to share my story on a number of fronts. As one of the first members of the medical school that welcomed med students into the program, day one, year one of medical school, I'm the first faculty member they meet. We have this program in our school that starts off wanting to bring all students and trainees, all stripes, colors, no matter what, up to one level by introducing them to a broad section of different topics. So it's nothing about the systems. They're not yet learning about blood pressure or hair loss or toenail fungus, as I like to joke with them. So they meet me, and over the years I've developed, honed, worked on this story about something really personal that occurred to me during my own training, in a way to be able to separate myself from all the other teachers that they'll see during their training, to hear this one message that I hope that they keep in their heart as they hunker down and continue on their journey. I, being a family medicine physician, had to do a 2-year residency training after my medical school. Residency training is the extra, the postdoctoral type work that med students have to do to develop additional competency in a field that they can then certify in. I was 4 months into my residency training. My med school career was incredible. I was very privileged and lucky. I was top of my class. I was a student leader. I was a fixer and a doer, and felt quite privileged to hold that role amongst my classmates. And that just sort of rolled into my residency. A lot of young energy and momentum taking me through my early days, loving every step of it. And what young people tend to do is sort of, we forget about ourselves and just aspire for greatness. Things like health and wellness become non-issues. But I had this little tiny health issue that seemed to niggle at me. In med school, it niggled at me. In the early days of my residency, it niggled at me. And I was like, oh, you know what? I just got to finally address it. It wasn't anything fancy. It wasn't anything death-defying or heart-stopping. It was a dental abscess. Something as simple as a dental abscess. And so I learned in school, when there's something like an abscess, we have 2 strategies. It's pills or surgery. And I was a big chicken, and I hated surgery. I hated the notion of surgery. And I loved my teeth, and I didn't want any of my teeth taken from me. My wife, thankfully, is much wiser, much more sensible and logical. She was a public health nurse. And she said to me, go get your teeth done. Go finally see a dentist. And so I did. I went, saw a dentist. Dentist said, oh, you know, your teeth, you have trapped wisdom teeth that are growing in sideways. You need to go see a dental surgeon. I'm like, okay. Had a bit of time off of my training, went to see an oral surgeon. And sitting in the waiting room on reflection now, this is an event that stands out for me very clearly. I had the patient intake, client intake form. Many of you are familiar with it. Name, date of birth, address, list of medications, medical conditions. So I'm just filling it out. Healthy, 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 nothing to report, nothing to report. Turn it around. A little bit about me. I had chosen the one oral surgeon at the time who actually cared about me as a person and wanted details about my past, with all due respect to the oral surgeons in this space. So there was this one line, it glared at me, and it still haunts me to this day. Occupation. Well, I'm a doctor. I was proud to be a doctor. No, that wasn't me. I hated mentioning that I was in medicine, because then you have that awkward conversation at a dinner party where they're like, oh, you're going to be a doctor. Can you see this? And so I learned a long time ago in my training not to mention that. And so I stared at it for the longest time thinking, what do I write in this space? So I wrote what I normally write. Double major, engineering and linguistics. It's a powerful party trick, because no one knows what to ask you. I can pretty much guarantee it. Next cocktail party, say that. There's no other experts in the space. They won't pry anymore. So I didn't. I wrote family medicine resident. So I go meet the surgeon, looks at my x-rays and said, that's no problem. Flips over the page, goes through my history, and then goes, uh-oh. You quickly learn there are certain people in your life that you never want to hear uh-oh from. The pilot, the plumber you've just called in the middle of the night to fix your toilet, and the surgeon who's thinking about cutting into you. And so I'm like, what's uh-oh? He's like, well, 30 years of being an oral surgeon, there are only 3 groups of people I ever have complications with. Nurses, lawyers, and doctors. To which I said, you know what, I'm really not a doctor. Engineering, linguistics, double major. He's like, no, it's fine, George, you'll be fine. I do this in my sleep. I wanted him to say, I do this fully awake, without medication, and I know what I'm doing. So that night, I go home, and the first thing I think is, I'm not doing this. There's no way I'm doing this. My wife, being lovely, said, no, you're going to do it. Remember, a good friend of ours, their relative is actually an oral surgeon. Why don't we call them? So I call back and say, you know what, something's come up. I can't come for the date I'm expected, but I'm available this other day. Any chance Dr. So-and-so is available? And they said, of course. And so I went. And I met with them, and they had read my file, and they said, this won't be a problem. Just lie back. We'll start some medicine, and you'll be fine. And the last memory I have at that time is kind of looking to my side and seeing a computer screen. And now this is 2003, so no iPhone photo streams. This is like old CRT computer monitor and pictures and a slideshow for Windows at that time. And I remember seeing my friend and then going to sleep. And then my next memory is waking up in the ICU at University Hospital and having a tube in my throat attached to a machine that's beeping, my wife in the corner crying, and thinking, this is such the oddest experience, and wanting to get up. And in getting up, setting off an alarm, because at that point I hadn't realized that I was physically restrained, 4 points restraints, which we don't use anymore. I was intubated, ventilated, and so as I tried to move, the room fills with people. A nurse is saying it's going to be okay, and I go back to sleep. I wake up again, still same machine. My wife is still in the corner, but I have a friend who's sitting at my bedside. And before I can say anything, he whispers in my ear, you're in the ICU, George. You're intubated. You have 4-point restraints. If you move again, this room will fill, and you will then be put back to sleep.
Kim, would you be so kind as to lift the microphone to you, and so those of us who are older can actually hear with them?
Thank you. My apologies. All you missed was my voice cracking. So that triggered a series of events where I learned very quickly not to move. You learn in a situation like this, things like 4-point restraints really do keep your arms and feet in place. That a urinary catheter is never long enough. The bag shouldn't be at the foot of the bed, it should be at the side of the bed. That everything that you see in the Hollywood movies about an intubated patient talking while the tube is in place is actually very accurate. That tube doesn't let you talk. And that when you're conscious but intubated, the machine never breathes for you fast enough. It was about 2 days, is what my wife tells me. I had lots of visitors, lots of tears. Apparently, in the darkest moments, I wrote on a board, just let go. At that time, my wife had determined the best way to communicate, because the team in the ICU had seen it best fit to leave me intubated, that I couldn't talk, but I wanted to communicate. That was amply clear. I'm a talker. That's what my wife would say. And so I had this board, and that's what I would write on. And apparently I wrote just let go, which she interpreted as I don't want to live anymore. And then the room flooded again. A lovely nurse came, gave me some medicine. I went back to sleep. You'd think I would learn, but I'm a man. That's what my wife would now say. It takes a man 18 tries to get it right. And so upon waking up for the 4th time, I obviously learned. Old dog, new tricks. And eventually went through the process of becoming extubated, tube coming out, being free from the physical binds that had trapped me in the ICU. And was prepared to go home. My wife, who had spent the better part of 4 days in the ICU crying, realized I couldn't even do the simple thing of touching my face. I'd become so weak. Our lovely ICU nurse, who spent hours just sitting in our space and talking with us, was kind enough to roll me to a shower facility and left my wife and I in this space, and she would just coach us. This is how you will wash him. This is the care that he's going to need when he goes home. And slowly the notion sunk in that I wasn't going to go home the way I was before I got here. And so that's what started our journey. The next memory I have is the neurology resident who was involved with our care coming to the bedside, preparing me for discharge and saying, well, George, here's your prescription for medication. You're on a list of medicines now to stop you from having seizures. Here's another list of medications to stop you from having tremors. And here's another list of medications to stop you from being so tired. To which I responded, okay, I have to go to work on Monday. Can you write me a note saying that I'm going to be late? because the timing for the medication was going to get in the way. And she looked at me and she's like, oh yeah, sure. And she proceeded to pull out a prescription pad to start to write. My wife had this horrified look and said, are you actually letting him go to work on Monday? And thankfully, that's when the staff neurologist came into the space, looked at me and said, you're not going to work. You're going to go home and sleep. You'll be lucky if you go to work by September. This was December 2003. The following weeks are all a blur. I have small memories of trying to eat soup and thinking this spoon was shaking so much as it was coming to my face, and thinking I'm never going to eat again. At that time, I'm not the foodie that my friends would say that I am now. Had I been, clearly it would be much more of a torment at the time. I remember my parents coming to visit. At the time, my parents didn't live in our community. It was just my wife and I and no other family, which really shines a light on the loneliness that I now appreciate that she would have felt in all those days and weeks following that hospitalization. And I have this memory of my father lying at my bedside just crying. My parents are immigrants to the country, and so they had seen me as this invincible, firstborn, oldest. Nothing could go wrong. I was the perfect child. But they never came to visit when I was in the hospital, and that was a really sore point between my wife and my parents that only recently has healed, because my parents were able to say to us as a couple the reason they never came to visit. Was they didn't think that they would ever be able to leave, that their heart would break seeing their son on a breathing machine. So that was Christmas 2003. I spent 3 solid weeks in bed, sleeping my life away. Shortly after Christmas, my wife said, you know, it's time for us to go and get some help. I was taking my medication very regularly, but I had no notion of today or tomorrow. To those that are on medications for seizure disorder, benign tremor, chronic fatigue, you have a sense of the thickness your skull feels. Now when I see patients and they're on combinations of medications and they say to me, you know, Dr. Kim, I feel really thick-headed, I'll say, it feels like your head's in a bucket. And they say, yes, that's exactly the feeling. A bucket that you can't get off. Everything echoes, it feels heavy, it weighs a ton. I remember thinking, how am I going to get better? I've got work to go to. I have a residency training program to finish. I'm going to be a family doctor, deliver babies, work in the emergency department, do anesthesia, do simple procedures. I had this future that I needed to accomplish, but I couldn't get to the bathroom, let alone crawl out of bed. I went to see my family doctor, and I have this memory of sitting in this space with her, who's now a colleague of mine. That visit was the last visit I could have with her as my doctor, and she realized she couldn't be my doctor anymore because we just cried. She wasn't sure what she could do for me, but she listened. She knew that at that time, the one thing that I needed was someone that wasn't my wife, wasn't someone in a position of power that was going to affect my residency training, wasn't someone that had to make a decision about what medications to change, but to be that person that I could just bare my soul to and cry and cry and cry until there was no more crying left to do, and then cry some more. And I remember her crying with me, which is why to this day, to my trainees, I will often say, if you have to cry, you should. It is not a vulnerability that as providers we should hide behind or hide from. It is a humanism. It is a humanistic trait that our patients will thrive because they want to know we're real. And that's what she taught me in that moment. I subsequently went to see a series of specialists who told me that I had a hypoxic brain injury. In coming out of the anesthesia for my wisdom tooth surgery, I have this weird enzyme that doesn't allow me to process medication the same way as others. And so I'm going to sleep longer. I need less medication, and I'm going to sleep longer. And so when after 2 hours of my procedure, I still wasn't waking up, the team should have realized that I was not breathing. They thought I was pretending. And so I went long periods of time with no oxygen to my brain, which led to the anoxic brain injury. It was a 2-year recovery period, lots of medication, lots of rehab, multiple attempts at trying to come back to my training program. At that time in your residency training, if you had any long lapses, it wasn't that you then had to add time to the end, it was that you were asked to leave the program and start all over again. And even though I'd only been 4 months into my training, by this point where I had to make a decision as to whether or not I'm able to go back or not, it had been 6 months. And my program director said to me, you have a week to decide. If you don't come back, you're out of the program. And again, at that time, being 27, being on medication that affected my ability to process information, all I could hear him say was, you're not going to be a doctor anymore. So I did what I shouldn't have done. I said, I'm fine, let me go. So the next week, I got on the city bus because I can't drive. I had my license taken away from me, so I couldn't drive. And so I took the London Transit. And I took the bus to Parkwood Hospital for my 1-month rotation in geriatrics. Went to the floor, did what was instinctual at that time. Though I had this brain injury, I had this instinct of what I was supposed to do. And so you grab the cart with all the charts, you talk to the nurse, you wait for the staff doctor, and you get ready to see all the patients. I went to go push the cart, and I couldn't. That thing weighed a ton. It had brakes on it, apparently, but I didn't know that because my brain wasn't working. And there was the poor charge nurse looking at me thinking, what is that monkey doing? And then my staff doc came. She had heard my story, being a small community of trainees and teachers, word spread. And so she knew my story, and she looked right at me and said, what are you doing here? I said, trying to move the cart. How about you? And she said, you have to go home. You're not ready. And so then I took the long 1.5-hour bus ride back home and hid in my room and cried some more. Called the program director and said, it didn't work out. The supervisor's away this month. Maybe you should put me on a different block. And he said, okay. So the next week I went to the pediatric emergency department to try my 1-month rotation in pediatric emergency medicine. Went to my service. Wouldn't you know it, the doc I was working with was just coming back from a 2-year leave of absence from an acquired brain injury. At that time, I didn't have a lot of faith. I wasn't religious. But that day made me religious. God was sending me a message. If I wasn't going to listen to the staff doc the week before, well, I'm going to find you a staff doc that had a hypoxic brain injury and had to take a leave of absence for 2 years. To make it even better, his name is George. I made that part up. And he looked right at me and said, you can't be here. It took me 2 years to get here. You need to go home. You're not listening to yourself. So I went home and cried some more. And then realized there's a journey ahead of me that I can't control. I say this to my patients all the time. There's the known and the unknown, the controllable and the uncontrollable. If we waste our energy with the uncontrollable, we miss the things we can control. What I missed was this box on my dining room table. The box was from friends. The thing about residency training is you spend 4 years with 95 colleagues in med school. It's kind of like kindergarten. You're together all the time, go through all the developmental stages of being a trainee, and then at the end of 4 years, you all disperse and spread around the world. And so my community, my set point wasn't there in my recovery. It all fell to my wife. But there was this box on the table. And so no word of a lie. I come home from the pediatric emerge, and I come in, and I'm like, there's a box. And there's a little note next to the box, and my wife's handwriting, and says, this arrived in the mail 2 weeks ago. When you're ready, open it. And it had come from my classmates who had all kind of heard the message. And remember, this is back before Twitter, Snapchat, Instagram. Like, this was old school messaging. People were like picking up the phone and calling each other and saying, George is sick. And so I sat at the kitchen table and opened the box. A bag of cookies, 2 seasons of the television show 24, and $50. This is back before Canada Post opened your mail. You could still send money in the mail. $50. Why $50? For taxis. There was this lovely note in the box for my classmates saying cookies, because they know I like cookies. TV, because I have all this free time now. And $50 so I didn't feel trapped in my home. That I could go anywhere I want, call a taxi. In this day and age, it would be Uber, right? It'd be Bitcoin people would be sending me to ride Uber all around town. And so, being mindful of time, I'll wrap up my story with 2 really important take-home points that I use these today as a healer in my clinical space as I see patients. In this day and age of Google and the internet, medical knowledge is no longer proprietary. As doctors, nurses, healers, therapists, we don't own medical knowledge. Everyone has it. My patients come to me with their diagnosis already. They know what they have. Dr. Google told them. And so I no longer hold the knowledge as a tool of power. And so we shouldn't use that knowledge or the words that we can pronounce so eloquently and easily as a sword or a weapon. Words aren't meant to compensate for our lack of ability or insecurity. Spend time with your patients and clients. Sit with them. Don't use words as power, but use words as comfort. All the people that cared for myself and my wife in the years in my recovery, we remember them because they sat with us. They answered our questions, complicated and simple, never made us feel stupid, dismissed, or alone. The other is when someone's unwell in your life, don't ask them what you can do. Because when you're unwell, you don't really know. I'm just tired, my head hurts, I gotta take more pills. I have no idea what you can do, just do it. So my senior resident at the time, so one of my mentors, she called a week after I came home and asked my wife, are there any food allergies? And she said no, and the senior resident hung up. The next day was at my door with a big pot of chili, 5 seasons of Friends, $150, and a Blockbuster gift card. Now, there are some people here who won't know what Blockbuster is, but there was a time that it wasn't Netflix. You actually had to get in your car and drive a couple of blocks and go get a movie. And we remember that to this day. That recipe for those beans, those are the beans we now make when we go to visit friends who've just had a baby, who have just come out of hospital after a surgery, who are mourning the loss of a loved one. We call them Tanya's beans, because Tanya was my friend who came to feed us, because food was so important. So, in the absence of knowing what to do, there's always something to do. And it will be appreciated one way or another. Thank you.
Oh, George, thank you. In every dark cloud, there's a silver lining. And you've come out of this, you had your sense of humor probably to start with, but you've come out with empathy and compassion that is just so striking. Thank you. We're going to hold the discussion until all of our speakers have had a turn. We're going to ask Ellen if she would share her story next.
Can everybody hear me? Yes? So, my name is Ellen Rosen. The first I heard about my diagnosis was as I awakened in the recovery room with my eyes still closed. I heard the resident giving report, and what I heard was, in quotes, she had a small bowel anastomosis, end quote. I knew then that my worst fears had come true. So I am a retired executive from LHSC. My clinical background is nursing. I taught nursing at university and community college. I provided clinical education in the specialty of obstetrics and gynecology, cancer, and palliative care. I had clinical and administrative responsibility for every clinical service at LHSC and retired as a vice president of Women's and Children's Clinical Services. Over my 40-year career, patient and family-centered care was front and center in my mission, and many programs that support this philosophy are still in operation today. My journey with a diagnosis of gastrointestinal stromal tumor, known as GIST, a very rare tumor, began 5 years ago, actually this week, when I started to have bladder symptoms. After 2 months of tests, I had surgery for what was likely a benign mass. Because of my clinical knowledge, when I heard the resident in the recovery room, I knew the worst had come to be. I guess overhearing the residents was not the best way to find out. My surgeon visited me a few hours later and confirmed that it was cancer. Often healthcare providers forget that hearing is the last sense to disappear and the first to return. Best to have these conversations away from the bedside, as you don't always know that hearing has returned. I met with our oncologist several weeks after surgery, and he confirmed this diagnosis and told me that the mean survival time was 4.9 years and that there was a medication that had proven to be effective. Following discharge, I sought a second oncology opinion at another center in another city. And part of that visit required meeting with a surgical oncologist. After a long wait in the waiting room, introductions were made, and the surgeon started by pointing to the operative report and asking me who the doctors were. I explained that my surgeon was a gynecological oncologist with training as a cancer surgeon. The other names were residents and fellows, I assumed, as I didn't know. She continued to ask why a surgical oncologist was not involved, as the surgery required removal of part of the small bowel and resection of part of my bladder. When I became teary at the suggestion that my care had been less than standard, she commented that I seemed to be upset over the diagnosis and offered me the services of a social worker at this center. She also said that if I required further surgery, I had to have it at that center. This meeting was so upsetting, undermining my confidence, yet knowing that my surgeon here was so excellent. What is the point of putting doubt and fear in the mind of a newly diagnosed cancer patient? We waited several more hours to see the oncologist specialist, who was helpful and kind and gave us hope for the future. We returned home by train feeling so downhearted and saddened by the experience. We then met with the local oncologist who specializes in this cancer and began treatment with a drug that had not been available 9 years before. It is called a targeted agent, which attacks the protein of any cancer cell that might appear until it doesn't. Over these 4.9 years, only once did I see a resident that led to a second upsetting event. As my condition is monitored by CT scan every 6 months, I then wait to see the oncologist several days later at his clinic. As you might imagine, these few days pass slowly with little sleep and thinking the worst. In fact, I always rearrange my CT scan appointment to be as close as possible to the oncology appointment. This time, a resident came to see me first. She introduced herself, and when I asked her if she was a resident or a fellow, trying to understand her level of expertise, she answered, resident or fellow, it doesn't really matter. She then started to go over my history, and as part of that, she said I had liver metastases. I knew this was not correct, so I told her that was not true, but she argued back with me. She then asked me several more meaningless questions, and when I asked her, what about my CT scan, her answer was that she forgot the report and could not tell me. By this time, I was very upset, as was my husband. Did she not know that all I wanted to know was the results of the scan, as this is the only way to follow if my disease recurs? Did she not realize that for me, these visits are terrifying? Did she not read the scan results before she came in the room? I answered a few more of her questions politely, And at this point, the oncologist came in the room and could sense the level of tension. In fact, you could have cut the air in the room with a knife. I asked him outright about the liver mets, and he confirmed my knowledge, and then he said my scan was okay. We reviewed once again what he has told me on my first visit while the resident was still there, and talked about when we would meet again. I left the room as upset as I was when I first heard about this diagnosis. I was back at square one with my anxiety and fears. I was able to meet my oncologist again 2 weeks later and shared how that experience was insensitive and thoughtless and cruel. I told him that all doctors, and especially oncologists, need to have a sense of what the patient is feeling and need to be a good listener. He listened intensely, and when I told him my terror as I wait for these results, he was taken aback and offered several options as to how to minimize this. When you have a serious disease, you hang on every word and every facial expression of the doctor, and you fear the worst when it does not seem right. We have nothing but praise for the nurses who cared for me. I had been their boss for years. They treated me with respect, as they did other patients. They did not hesitate to comfort me and support me through long, sleepless nights, even though I was watching Netflix at 3 in the morning. I am thankful for the skill of my surgeon, in whom I had total trust. Totally thankful for the knowledgeable, caring, thoughtful oncologist and nurse who listen and respect my fears and my need to be in control over that which I have no control. The lessons are clear. Perfection is not required, just thoughtful and kind interactions. Take a minute before going to see a patient whom you've never met before to find out more than just the disease. Try to put yourself in their position and think about how you can add value to the visit. Undermining trust and arguing with the patient is not an effective way of communicating. Thank you.
Oh, Ellen, so compelling and so many lessons for us. I'm sure we'll have lots of discussion. So finally, Shannon.
Hi. So first of all, kudos to Lisa for arranging our new furniture. Isn't it nice? We're going to do this every time now. So I am often at the podium doing the moderating, and a real thanks to Sandra and the awkwardness of telling you about how I went from being a doctor to a patient is the same as being a moderator to the speaker. So there's ways of building empathy. But my name is Shannon Arntfield. I'm an OBGYN at Victoria Hospital, and I'm the mother of Amelia, who's going on 10, and John, who's going on 7. I'm the wife of Rob, and he's an intensivist at the ICU. I am quite accustomed to speaking publicly, but not about myself. I am more introverted than people realize. And although I am willing to be vulnerable, and I actually think it's really important, it is not necessarily enjoyable. So although some of the people in the room, and thank you for those of you who love me and came for me to be here tonight, some people know a little bit about this story, but I've never shared it, ever. So I feel all the feels as a person. That's a big part of who I am. Rob can tell you stories later. So I'm pretty sure I'm going to cry at some point, and that might be uncomfortable for me or you. So my illness is a series of events and complications that happened during my first pregnancy with my daughter, who I didn't know was a girl at the time, and they were made more complex because of my circumstances, because I was a trainee at the time. So George went through a 2-year residency. I went through a 5-year residency. It's a surgical specialty, and I was working about 80 or 90 hours a week. And the time I got pregnant, I was in my last year of my training, so I was doing something called chiefing, or chief resident, and that's a period of time where you have extra clinical and administrative and educational responsibilities. So I was responsible to a team of residents that were junior to me and students who I was supposed to be leading and guiding and teaching. I was responsible to a team of surgeons who depended on me for service, including operating, seeing their patients in clinic, dictating, that kind of stuff. I was responsible to the patients, obviously. I was operating or seeing people about 8 to 10 hours a day. I was wearing a pager 7 days a week, 24 hours a day, so that I could come in after hours for after-hour emergencies. And I was responsible to my own learning because I was going to be an independent practitioner the following year, so I was studying for my board exams, which is a yearly event. You have to pass them to be able to practice. And in the midst of all of this, there's this sort of general rule of residency, which is going to become important about the eat when you can, sleep when you can, pee when you can. And I had really drank that Kool-Aid. I'm very responsive to authority. If you tell me to do something, I will do it. Having control over your body and putting yourself last was something that I expected of myself. So this may sound like a ridiculous time to have a baby. And I know that you were all sitting there thinking, why did she do that? And I'm sure a number of my colleagues thought, why did you do that? Both at the time or after. But the flip side was I had spent 9 years training. And I was going to enter into a professional demanding career that was not going to get simpler. I had no ability to have a maternity leave in my personal practice that I could have through residency protection, payroll. And I knew that fertility does not last forever. So I especially knew that. So I was 30 at the time, and I felt like I delayed a lot of things, and I didn't want to delay being a mom. So I took it on, and Rob and I talked about it, and then the following happened. And it was sort of insidious. In the beginning, I had nausea, vomiting, fine, except that not everybody is just pukey in the morning. I was someone who was sick all day. If you see any pictures of me in the pregnancy, I am on a couch. It was like having the flu for 3 months. So that's fine, except that I was trying to see patients, and I later learned that the impact of bad nausea and vomiting is sort of like having chemo. There's a really great study, actually, saying they're basically comparable. So I was doing that for the first 3 to 4 months, and then when that ended, I got migraine headaches, which I'd never had before. Shout out to anybody who suffers from these. They are absolutely incapacitating. Rob came home and found me on the bathroom floor I didn't know what was happening. So that lasted for 2 months. I got them every 3 to 5 days. I had to see a neurologist because we didn't know why they were happening, and then I couldn't have any of the treatments for migraines because they were contraindicated in pregnancy. And then when that ended, I ended up having threatened preterm labor. So I had my first bout when I was 26 weeks. I was operating that day, and I had to leave the OR. And then I was sent home for a couple of days. I contracted every 2 minutes. And that's a stage where your baby is not likely going to survive, or if it does, it's going to survive with some really serious disabilities, and I knew that. And then I had this second sort of bout of it that lasted for a number of weeks, starting around 30 weeks. And I had to be taken off work totally, and I was put on bed rest. And then after that, I got a condition called cholestasis, which is a liver problem, and it carries a stillbirth risk. And so that led to a decision to induce me. And then I had a really awful induction, and a day and a half later, I was septic, and I had a section. But at the section, I had a big bleed, and because I was septic, Amelia, ultimately, that's what we named her, she had to go to the NICU. So I couldn't be with her. And then when she got to the ICU, even though you would have thought that would be the end, she had this weird bit of bloating, and her tummy swelled up, and they wondered whether she might have cystic fibrosis or Hirschsprung's or some other intestinal problem that you have to operate on. So then we had to wait for testing for that, and then big surprise, although it was to me, I got a big postpartum depression, which was unrecognized and undiagnosed and untreated for about 9 months. So I see in retrospect that it was a total setup for that, but no one picked it up at the time, and I didn't say anything about it. So that's what happened. And the themes, there's 3 themes that for me came out of it, or come out of it, that I would thought about sharing for tonight. And the first is that illness is not the same thing as disease. I talk about this with the medical students. Disease is something you can diagnose and is very defined, so migraine headaches. Illness is what the patient experiences when they have them. And so having preterm labor and going back and forth from the delivery room to the ward and back and forth is very different than the definition of contractions that lead to cervical dilation or not. So the context of my illness is what made the context of what was happening to me is what made the illness. And a lot of that was about this overwhelming sense of failure for me. So my pregnancy was having a negative impact on my work, and my work was having a negative impact on my pregnancy. I couldn't perform the way I expected myself to, or the ways that other people needed or expected me to. And that felt like a failure. I could not subjugate my body. I could not tell it to not do or to do. I just didn't have any control over it. And that felt like a failure, especially after drinking the Kool-Aid. The inability to care for my baby the way I felt like I should felt like a failure. And the inability to be a good patient felt like a failure. So I had this lovely OB. I picked him on purpose. I really respected him. And then I was having this dumb pregnancy where things just weren't going well. And both of us were wearing multiple hats. So there was the resident trainee supervisor, and there was the patient physician. And I don't think either of us really knew what to do with that. I think we did our best, but it was hard. And then, of course, I had chosen to become pregnant, so I had this sense of shame about I should have known better. And I felt even more the need to just push myself, because here was my bed, I better lay in it. So I, in addition to that, because I was a resident, and because specifically my illness was occurring in the same department I was training in, made it really hard to be a patient. And so one of the times I was being treated for preterm labor, so I had to be admitted, but then they put me, there's ward rooms and there's shared rooms and there's private rooms, and I got a shared room because that's what my insurance covers, but I was beside the patient that I'd rounded on that day. And that was really weird. My junior resident came in at another occasion. I was 30 weeks at that point. I was getting full treatment for preterm labor because we all sort of thought the baby was coming. I was getting injected with steroids, which happens in your rear end. And the junior resident came in and needed to ask me questions about a patient. And that was really weird. And I didn't know how to manage that. So the lack of control over what was happening to me and the lack of privacy ended up also ending sort of with a lack of, it got added to this lack of credibility. And so on one of the times of my sort of contractions, I'd been discharged from the ward for home. It was Christmas Eve, and I was home for less than 8 hours, and I was back. And there's a very senior obstetrician on, there's a very senior nurse, and everybody thought it was going to happen. And they give you large doses of narcotic to try and abort labor. But I had I had a really I had a known reaction to narcotics, and I basically had a temporary psychosis. And I wanted to crawl out of my own skin. I can't describe the feeling. It was so awful. And of course, you don't totally know what you've done or said, but I was with nurses I really respected. And I didn't deliver, and I was pissed off because by that point, I'd been back and forth, and, there's this phrasing we sometimes have about the patient's unreliable. It was a very low point. And my the OB, it was not mine, but he was on call that night. I really respected him, and he came in the next morning, and he looked at my face, and I don't know what I said or did, but he was like, "You feel like you've lost all your credibility." And he just totally nailed it. And the naming of the fact that I felt shame was really powerful, and that I didn't have to feel it. I think that's what he's trying to communicate. He's like, "Shannon, if people knew when the baby was going to come, the job would be a lot easier." So the lesson on this theme is that I think severalfold. One, the main one is that healthcare providers, I think, need a bit more permission to be patients. They're inhibited from asking for what they need, and they may have really be struggling with being unable, and they expect themselves to just push through. So the change to my practice was having an index of suspicion for this kind of thing, trying to be really perceptive and probing it and asking about it, because I think if someone had really pushed me about whether I had postpartum, I probably would have said. And also that I think healthcare providers don't have a great mind-body connection, and I certainly didn't have any. And I think recognizing that your provider colleagues who are sick may not know how to listen to their body is important, and I definitely think it can make it worse when you don't. So the bottom line to that is I just think there's a big role for kindness, and I think that's what I think my colleagues have said tonight too. Especially because I don't think providers give it to themselves very easily, or at least I didn't. So theme 2, the rest of them are the other 2 are quite quick to explain. So the therapeutic relationship and the importance of it, I often felt really alone. Medicine hadn't really been able to help me very much through the problems I had. There was no treatment for the migraines, there was no treatment for the nausea, vomiting, there's no treatment for cholestasis. And also a lot of the problems were fairly invisible, so you can't really see that someone feels like they're gonna barf all day long. And my colleagues were busy. I didn't have a lot of friends outside of medicine because I was busy. I hadn't grown up here. And the colleagues that I had in medicine had the same mindset as me, which is just that you just deal with it. So the therapeutic relationship with my care provider was really important, and it came to pass that I finally admitted to him when I got the liver problem, which is the cholestasis thing. I finally admitted to him that I didn't think I could stay pregnant anymore. I was really, really scared. I'd cared for a patient whose baby had died from this condition. She was the same gestational age as me when I was diagnosed. Her baby died 2 days later. And my mom had lost twins at term. So I was very aware that it didn't matter who you were, just bad stuff happens. So I went to him, I said, "I'm scared," and he induced me, but then the labor was really bad. And so I had a big fever. Day and a half later, they take me for section. And my OB had come in just for me, which is definitely a privilege of being a care provider. I recognize that, and I was very grateful for it. But it was important actually at that moment because the whole rest of the team, anesthesia, nursing, everybody else got called away to an emergency in another room. But by this point, I was in the operating room. I was naked. I was strapped to a table. I was really sick. And my OB, who could have done other things, came to the side of my bed, and he held my hand. And he didn't say anything, but he just sat there and he held my hand. And the knowledge that I was not alone was overwhelming, and it was permanently imprinted in my brain, and I do it with all my patients. Because the lesson to me was well above and beyond anything you can know or you can do, you can be a human being with another human being. when they're sick. And that was very powerful. And the last theme is just that the experience of becoming I was discredited, and I was sick, and I was unable, and I was vulnerable, and I was powerless, and I was all of that, taught me more than a 5-year residency did about how to care for people. And I really appreciate having learned that. And I would never wish that kind of learning on anybody. But I do think there's something incredibly powerful that happens when we become vulnerable. And I think that when we're open to it, or we are forced into it, kicking and screaming, I think that you can develop a connection with other people that stays with you about the need for it and the importance of it. And that's all I have to say.
Oh my gosh, Shannon, thank you. And thank you to all of our speakers for sharing their individual experiences, different and similar, and thank you. So now it's your turn as an audience. You've been listening to share your reflections about what you've heard. What resonated for you, and maybe why? Have you gained any new insights? Do you have questions, specific questions for our storytellers? And I'll facilitate your questions to whoever you want to guide them. There's a glaring light, and it's hard to see.
Can I just add, it doesn't have to be questions. It could be reflections or thoughts on how the stories impacted you.
Absolutely.
As well. Yeah. And there's a microphone at this side and one over here, so we'll come and find you. Thank you. I just want to thank all of you for sharing such powerful stories, and it's not easy to be vulnerable in this setting, particularly as a healthcare provider. I think particularly Dr. Kim and Dr. Arntfeld, you shared how it informed your encounters with patients. And I have two questions. One is, how much would you share with a patient? And we're traditionally taught to have this sort of boundary, and we don't transgress that boundary. And do you feel that it's therapeutic to transgress the boundary at times? Or does it leave you somewhat less as a professional? And the second question that I have is, have you had any experience with our OMA or our physician wellness initiatives? And have they been helpful, if so?
Thank you for the question. To your first question about boundaries and sharing with patients, interestingly enough, it's something that I try to explain to my trainees often. In this day and age where healthcare has become increasingly litigious, as providers, sometimes we hide. Again, behind the shield of power, the words of knowledge, somehow we have to hide our humanness for fear of this demon that's known as a boundary. And so often what I'll say to our trainees is, boundaries are fine to cross. They're not meant to be walls that we have to physically climb over. But there's a delicate balance where we weave back and forth, we dance. There's a difference between a boundary violation and boundary crossings. But crossings occur all the time in the work that we do. There's a depth to the connection that we have with those that are frail, vulnerable, and sick that has to be a part of our work. Otherwise, we're missing things. And so I will say that to trainees often. Interestingly enough, that my story I don't share. Periodically, when we're talking about side effects to medications and kind of having that thick-headedness, that's a metaphor I use often. There are other illness experiences that my family has experienced that will be fodder that I will share in certain settings. And so my instinct isn't to hide it, but to deploy it when appropriate.
I don't often share anything specific about my illness. I'd be willing to if I felt like it was for the patient, which is actually the same lesson I learned about whether we cry with people, which is that if the tears are for you, go do it in another room, and if the tears are for the patient, go ahead. And I think I probably would use aspects of my story in the same way if it, and I probably on maybe 2 or 3 occasions have shared something about it for a patient who, in those circumstances, I think literally didn't have any other form of, there was no way that individual was feeling understood by anybody else. And then I'll use it when it's, I think, genuinely for them. I don't have any experience with the OMA, to the second question.
Thank you so much. I think in some ways it's your experience that you use in the relationship rather than your story that you use in the relationship, and that your experiences have given you what is true compassion, which is having suffered, really understanding the suffering of others, which is different than crossing boundaries, I think.
I got
Thanks. First of all, I really want to thank all 3 of you for sharing. I really believe in these kind of events to hear patient stories, and the type of perspective that healthcare providers bring in talking about their own stories is, frankly, I find even more powerful. And especially how you've parlayed it into teaching trainees and others. I'm thinking back to an experience where Dr. Philip Hébert was talking about his experiences. So he's a physician in Toronto and is diagnosed with Parkinson's. He's also written a bioethics textbook called Doing Right. But part of what he talked about with his experience of being a physician and then a patient was, and it's from a number of years ago, that his care providers didn't give the same kinds of explanations to him as they would have given to other lay patients, because they assumed it would be insulting to say those sorts of things to another physician. And part of his teaching now is to, if you have a patient who has some knowledge in the healthcare field at whatever level, don't make assumptions, let them be the patient, even if you need to just speak it and say, I'm going to tell the explanation of this diagnosis like I would tell to anybody, and I'm sorry if you find that insulting, tell me if I should stop, but to at least start with that kind of a baseline. So I'm just curious, in all 3 of your experiences, did you find that was happening with your healthcare providers, or perhaps that is from years ago when we've already moved on from that?
So yes, my oncologist gave me the same information, perhaps with more detail, because he knew I would understand it. And yet at the same time offered me space to digest it. At one point, about a year and 2 months after I started on the drug, they thought that maybe there was a change in the CT scan. And so the debate was, would I double the dose of the drug that I was taking? And he said to me, why don't you think about it and come back in a month and we'll talk about it again. And so I did, and I tried to research about it with the help of a friend who's here tonight, who was very kind to spend a couple of hours with me looking through medical literature, all of which was useless, by the way. And not because the literature wasn't good, because this disease is not common, and almost everybody is different. Anyways, I came back to him in a month with an annotated bibliography, and I don't know if you know what that is, but it was about 7 or 8 pages of articles that I had read, some of which were really weird. And I started reading it to him, and he said to me, "No, that's not you. No, that doesn't apply to you. No, that wouldn't work. No, you're not in the right group." And so I finally said to him, "Okay, we'll double the drug." So in that, he gave me space to I don't know, get control, to do my thing. I mean, I could have just said, "Yes, we'll double the drug." And then I got to see a surgeon really quickly, and he looked at the CT scan and said there was nothing wrong with it, and we carried on. So yes, I got lots of information from him.
And Ellen, and I hear you as a real partner in your care with that particular person.
I had a mixed experience with that, and actually an experience prior to my own pregnancy that had also was very instructive. In my own pregnancy, I found, and I think it's because I was in the same department, but people didn't know how to interact with me. And so one of the times that I talked about with the psychosis, like the nurse that was taking care of me, she was a very good nurse, but she was interacting with me as a resident. And that I found that, I didn't actually know that until later. Like I never put that really together at the time. And then in the same way, when Amelia, unnamed at the time, was born, because she was really sick, she couldn't stay with me. And so I didn't know that though, maybe because I was sick, but I did not want to be the doctor, and I actually had said that to my I said, I don't want to just make decisions. Tell me, but just be you, and I will be a patient. But that hadn't happened when the transition after the cesarean, and when they came to take Amelia away, I didn't know they were going to do that. And it was honestly one of the most painful experiences I've ever had. I'd waited for so long, and I'd been so worried, and now she was finally here, and they came as a team. And everybody looked at me as if like, what do you mean you don't know? Like, you're septic, of course she's... But I didn't know. And so that was painful. But then a very instructive thing that had happened earlier that has informed my practice is a resident actually several years ahead of me had very complicated pregnancies, and she had been admitted preterm, and in the same way was supposed to get those steroids things for the premature baby problem. And she was admitted, and this routine is the residents round, they do all the tasks, they tell the attending, who then sort of comes in later. But the residents didn't want to round on their own colleague. They thought it was awkward. But the attending didn't round until the next day. So she didn't get steroids. And it was a really big problem. Like, it was a really big problem. And so because she was not well. And so the lesson to me, and I actually communicate this with every single healthcare provider I care for, is I am going to treat you the same way I'm supposed to treat every patient, because my experience is that we over or we undertreat, and both of them have problems. So and I say, are you okay with that? And I usually ask them, how do you want to be? Do you want to be involved in the care, or do you just want to be, like, how do you want the relationship to go? And I usually, anyway, that's what I do.
During my journey, I had the opportunity to be cared for by multiple physicians in the same clinical department. In my recovery, I was followed by neurology for the longest time, and I had a main neurologist who I saw on a frequent basis. And what he did for me the day one, sort of after being out of the hospital and going for my first follow-up visit, still sits with me to this day. And he looked at me, he said, I know you know lots of things about what happened, like it's from a textbook. but you know little about what's happened to you as an individual. So we have a choice. I can be your physician and you can be my patient, and I'm going to treat you the way I treat all my other patients. Or I'll acknowledge you as a physician in training who's going to come to me with knowledge, and we can have a dialogue over how we're going to approach things. And I said, just treat me the way I assume I know nothing, because I did. I'm not going to remember anything, and so treat me the way you would normally treat me, which was sort of diametrically opposite to the experience I then had subsequently when I was readmitted later on in my journey with another neurologist who came in, looked at me and said, "You're a doctor, you know what to do," which was really awkward at the time because at that time I was in restraints again and having telemonitoring, and so it was such this sort of ethereal existential experience looking at a physician, looking at me, telling me that I should know better, know what to do, when physically I didn't know what to do, and emotionally I had no concept. And so I now have the privilege of caring for other providers in my work, and it's the first conversation I have when I meet them for the first time and I enter their care circle. I say, I'm a doctor, you're a doctor, nurse, physiotherapist, physician assistant, whatever. How do you want to see this relationship go?
Can I make a comment? So coming from mental health, and maybe there's a lesson to be learned from this. There are huge risks in being treated as a VIP, a very important patient/person, and we've had some awful tragedies in our own city, often going down the pathway of not doing the right thing because somebody is who they are, and then having an end result which is a completed suicide. So it's not exactly the same, but there are some risks in becoming the VIP and being treated differently because people are afraid to treat you like everybody else. There's also a flip side that I think I heard in your story, Alan, of not treating you as somebody who has knowledge. And some of the disrespect in the interactions that I heard were so hurtful to you. I think may happen to anybody, but they happened to you, and so that resonated tremendously for me. You were treated very disrespectfully in your journey by some people. A lesson in that for our trainees and for some of our grown-up physicians.
Hi, I'm an ICU nurse. I was an ICU patient when my son was born, actually. It's been really fascinating to listen to all of you speak. And I would like to say I went back to work without any expectation of having any long-term issues from my experience. Back to the intensive care unit. The only good point was I was a patient in CCTC and I was a nurse at the university campus. The good thing about being at the university campus at the time was we don't see a lot of OB/GYN patients. So when we did run into the odd one, I went into a tizzy, couldn't perform, and had to step away. I made that clear to my management, and they were really, really good about it, and that was terrific. Over the years, I've taken care of a lot of liver patients. I also had some liver failure. I ended up with HELLP syndrome. I've taken care of a lot of liver patients over the years. I've used my experiences as a patient in helping some of them. I've never hidden from my colleagues or from my patients my own experience. I don't share it if it's not important to the situation, but I'm quite open with it. And over the years, I think I've coped really well, and I learned to get over the fact that in February I don't sleep, and I just moved on because that was the expectation. It was the expectation of the physician group who took care of me. It was the expectation of my husband, who's also in healthcare, and it was the expectation of myself. So in all of those things, in sharing my story, I've had other colleagues come and share their stories with me. And a lot of it is around how we're not supported, particularly to come back to work. And you must find this, Shannon, that you work in an area that must remind you every day of your own experience. And so I think it's unfortunate, and I had, on behalf of a colleague, tried to seek out some help specific to healthcare providers who are undergoing a lot of stress around coming back to work after being a patient. And it seems that there's not a whole lot out there. And I'm not sure whether it's something that would be worthwhile trying to develop at this point, in that it sounds like there are a lot of stories, and I'm hearing more and more from colleagues around some distress that they have in coping when they get back to work, around having been on the other side of the sheets, I like to say. I just wonder if you have any insights into that.
Anybody want to go first?
Thank you for taking the mic and sharing your story in this setting. I would agree that as a discipline, as a part of society, the professional domain that's expected by the lay public to be on our A game every single day when we're at work, to be at our best, all of that should want to shatter that glass ceiling that prevents us from being really honest with each other, so that we can say, you know what, I'm not at my best today. These are my risks. These are my known triggers, to the point where our colleagues would then know, in anticipation of, oh, you know what, we know the next patient that's being transferred up to the ICU may be a trigger for my colleague. That multiple nights call is going to result in my colleague not being at their best. That it's implicit in the way we do it for each other. Until that happens, what we need to do is we need to have spaces like this, where souls are brave enough to take the mic and say, I have been weak, I have been broken, and the love of this community put me back together. But the love of the community I work in right now is going to continue to sustain me. Until we can do that, we just keep telling our stories.
It's a great question, and I agree with George. Just to acknowledge the Februarys in your life. I think many people do try and do something with their stories, whether it's events like this. I've tried to put it into teaching at the medical school and with our residents in my department. I think there's different ways you can enact it. I don't know, and you enacted one of them, which is going to your management and saying, I can't take care of that kind of patient. I think that, I don't have a great response for, there's someone very close to me who experienced, as a physician, experienced the death of his parent on a certain ward. And going back to that ward, which he has to do, is a big deal. But to not be able to do that means he can't do his job. So I don't know that there's easy fix. I think it's just one of the problem. It's one of the problems, and I think hopefully there's advocacy on the person who suffers, and hopefully there's awareness of people around them. But I think a huge part of it, as George says, is having language for it, and it not being, being vulnerable. The big lesson that I learned is being vulnerable is not weakness. Being vulnerable is courage. And until it's understood like that, I don't think there's permission. I think that's the first step. That's by Brené Brown, by the way, to not credit her.
And I think that was a very wonderful question as well. I think until we have a healthcare culture that is a compassionate one from the top, it's going to be very difficult for us to have the self-compassion and to be able to learn to cope with what we do have to cope with in a way that we feel supported. And I become distressed when I see that we may not have a culture of compassion that starts right at the top. I think we need that.
I had a question for Dr. Fistman. I was just wondering, I work in mental health. I was just wondering if you could shed some light on the same topic, like in mental health. Because I was just wondering if do you think that it's challenging for mental health providers to see another mental health provider as a client, and especially when you know so much about the field, and especially given that in mental health sometimes it's not the same as like medicine, because sometimes when you're using interventions which are not prescriptions, and so sometimes you might find yourself in a situation where you don't agree with what the practitioner is doing, that maybe you don't agree with the intervention he or she wants to use, or if you have ever worked as a client or sought help as a client.
Can I see if I understand, because you've asked a question with so many layers to it. So I think you started out by saying, should we be providing mental health care to somebody that we know outside of the therapeutic relationship?
No, I was basically saying if you're a mental health care provider yourself, how challenging is it for you to like work with someone as a client, because you already know so much about all the tools that he or she is going to apply on you, possibly.
So your question is, as a mental health care provider, providing mental health care to somebody who's within the field, how can you do that?
Yeah, because because in let's say in medicine, you're basically you either agree with the prescription that's being written or not. But in mental health, I mean, there could be so many things that could go wrong, and as you go through different phases of your intervention.
Mm-hmm. So, and of course, it depends on various situations. But as a provider to somebody else who is in the mental health field, who's come to me, and I don't have other knowledge of them, but we're going to establish a therapeutic connection, and we're going to work within that relationship. It goes back to we do much better for each other when we work in the context of a partnership. So if I have a doctor-centered therapeutic relationship and I believe I can tell somebody what to do, perhaps a little like Ellen's story of being able to go away, think about it, and come back and have input, that's much more likely to be a relationship that we can work productively within. I'm not sure if that totally answers your question.
Would you prefer that over simply being just a client? I think it was Dr. Rosen was saying that.
So I'm suffering, and I'm suffering in terms of my mental health, which actually is not that separate from my physical health. The two have an interesting interaction. And so I need to see somebody, and I get referred to see somebody, and I either do or don't make a therapeutic connection, whether I'm a healthcare provider or not. So it's going to depend on the context of that therapeutic relationship that we have to work within. And I believe it's a partnership, and it's not a one-way relationship dictated by me to, and I don't know if that...
Or would you have preferred to say engineering and linguistics?
I'm wondering, Sandra, we do have a networking and social time with food.
Yeah,
and,
perhaps we could talk about that a bit more
one-on-one
privately.
connection. This might be a good.
Yes, and then I may have a better understanding of what it is that's sort of at the core of your question. I'd be very happy to do that.
And we have time for one more question.
Okay, thank
And then
you.
we still connect. We have, time after this session here to connect in the outdoor area.
So one more question,
Yeah.
and
And as someone
It's right
thinks
here
about
in the
answering,
front.
okay,
It's also in the
yes,
front.
go ahead.
if there are any more questions, also just so you know, there's free parking. If you go validate your parking pass from, if you parked underground, if you go to the library before you have snacks, it'll still be open and you just need to show your library card and they'll validate it for you.
Thank you so much, Shannon. I had it in my closing comments, but thank you, that's really important. Yeah. So the last question, and then I'll say a few closing comments and thank yous.
So my question to all 3 or 4 of you is this, and that is that in your very busy, work, et cetera, we already established that it's very important for self-care, right? What do the 4 of you do to refill your gas tank?
I don't work anymore. So I have lots of opportunity to refill my tank. But in order to travel through this journey that I found myself on, not a journey that I planned for my life. In fact, just as an aside, I was really afraid of ovarian cancer. So I had my ovaries and tubes removed. Was really afraid of breast cancer, had mammograms all the time, but I never really thought about this weird thing. Anyways, so a couple of things. One is I sought the services of a social worker at the cancer center in the first year because I was just, I couldn't think of anything else. And in those days, I had to have a scan every 3 months. So I was spending 1 month out of every 3 months being anxious, sleepless, nervous, worried. And then I realized that if I didn't live that long, I was wasting 4 months out of every year. So that was kind of silly. And so I figured out how to get that down to just a couple of days. My husband and I are very lucky because we're able to travel quite a bit. And so the other thing that we've done is just focus on having fun and making memories. So lots of good memories, lots of support from friends, lots of people who are willing to distract me when I'm waiting for results. Knowing that there's a social worker at the end of a phone. Asking for help is really, really important. You have to know that there are people there who know a bit more about how to help you through the journey than you think you know yourself. So yeah, play lots of golf, go south in the winter, and every 6 months have a period of what those of us who have this disease has scanxiety.
Thanks for that question. I made a decision to not work post-call, which is a very atypical decision in my department. There was no one who did it when I started. So again, weakness. But I was a terrible mother when I worked 24 hours and then worked for the next 8 and then came home. And that wasn't fair to my kids. So that's one of the decisions I made. I'm very selective with who I spend my time with. So if you are honest and you are okay with someone else being honest, then you're great. And otherwise, I've got other things to do. So I would say who I spend my time with, and and yoga. Yoga was very good for a long time.
I love being in the kitchen. I cook all the time. I restore my soul by feeding others. I have a 10-year-old who wants to be the next Josh Donaldson. As a result, for the last 6 years, I've coached various house league baseball teams with the hopes of compensating for my lack of sporting ability by being that parent volunteer. And I have a beautiful 14-year-old daughter who is outpacing me on every single thing. Just watching her grow up And the most important thing is I married up. What I say to the men in the room, you know you scored when you marry up. And so I married up, and so every day, the light of my life helps me recenter myself. And so, for those that aren't in relationships, be patient and marry up.
So thank you all, and thank you all. But could you let us know by filling out your feedback so that we could do things differently if we need to, and also tell us what you'd like to hear at the next Patient Story Night, which would be in March. Yeah, in April, okay. Before we go and enjoy our beverages and snacks and make those new connections, I just want to make some important additional thank yous. So I do want to thank an organization that's on the bottom of that flyer called the Associated Medical Services, or AMS, Phoenix Program, because they provide us funding each year so that we can hold this as a free public event. So thank you to them. Thank you enormously to Lisa Hawthorne-Thwaite. Lisa, you're so committed to passionate about the importance of family engagement in shaping how we deliver the best healthcare that we can, and bless you. Thank you. And then I did want to thank our connections is Josh somewhere? Yeah? Oh dear, okay. So I was going to say our connection with Humanities at Western. And Josh Lambier has been our real connector with Humanities, and he very much, in his absence, I'll say, supports the connection between humaneness and literary stories and humanity and healthcare provision. And so that's a wonderful connection that really has been fertilized by Shannon. And thank you, Shannon, for fertilizing that. So thank you as well to all of our volunteers. Thank you.